Yeah, Dr. Haron, you can start showing your presentation.
Yeah, hi everyone. Good morning, good evening, or good afternoon, wherever you are. Thank you, Kavita, for the introduction. I'm Haron Obaid. I'm a musculoskeletal radiologist at the University of Saskatchewan here in Canada. And today is really to share my experience with you in terms of how we do MRI imaging of sport injuries. The theme of this talk will center around some practical tips for optimizing your MRI imaging of sports injuries. We will talk about general MRI principles, MRI protocols, specific MRI techniques as far as positioning is concerned, for example. And then we will move on to kind of a broader approach to musculoskeletal injuries. And we will look at it, we will take it in terms of tissue approach. So we'll talk about muscles, tendons, ligaments, cartilage, bones, and so on and so forth. It's going to be quite broad, and I will keep it pictorial just for fun. We will also put some emphasis on definitions and terminology, just to be accurate as to what terminology we use for what injury. And I think going back to basics and knowing the definition of the pathology is very important. We'll also cover some of the MRI pitfalls as we go along. I'm sure we all know that sports and exercise are very important for our mental and physical health. However, sport injuries come with a price. Sport activities come with a price. A study has shown that about 2.6 million emergency visits are actually related to sport injuries, particularly in the patient population of between 5 to 24 years old. MRI techniques, there are multiple factors that play into how you optimize your MRI imaging of sports injuries. We will talk about the scanners, the coils, the sequences, positioning, and planes. In MSK imaging, we prefer to use 3 Tesla scanner whenever it is available. And the reason for that is because it provides us with better SNR, and it has a wider bore, just in case if you have a bigger athlete. The disadvantages of 3 Tesla scanner is the artifacts. I'm sure you all know that all artifacts are augmented with 3 Tesla scanners. That includes metal artifacts, motion artifact, susceptibility artifact. 1.5 Tesla scanner is definitely another option. It's widely available. The artifact issues are minimized, especially if you have a patient with hardware. The disadvantages of the 1.5 Tesla scanner is obviously the inferior SNR. Coils, also it's important to emphasize that with MSK imaging or sport injuries, we would prefer to have joint-specific coil, such as a knee coil or a hand and wrist coil. And the reason for that is the more tailored the coil for the anatomy, the better the SNR and the higher the resolution. The disadvantages, however, of using a smaller coil is the smaller field of view. And if you had a patient who had a pathology that involved a larger field of view, such as, for example, hamstring muscle tear, then you would rather have a body coil to cover that large field of view or large anatomy. The disadvantages of using a body coil, however, is the inferior SNR. So it's more of a trade-off between what you really want to see and what anatomy you're dealing with, what pathology you're dealing with, and selecting the appropriate coil is always vital. Sequences with sport injuries, we always have to have a fluid-sensitive, fat-suppressed sequence in our protocol. And you have two options here. You either go with the T2FS or you go with the STIR sequence. But there are fundamental differences between T2FS and STIR sequence. T2FS is a fat-saturated technique using frequency selection method. And frequency selection method is a preferred option in MSK imaging. And the reason for that is because this technique provides us with better SNR and shorter scan time. The disadvantages, however, of frequency selection method is the inhomogeneity of the fat suppression. And that tends to happen if you had metal hardware or if you had complex airsoft tissue interface, such as in the foot and ankle. And in this situation, we would rather prefer to have a different method of fat suppression, which is the inversion recovery method. The inversion recovery method is preferred in circumstances if you had metal or if you had complex air soft tissue interface. It provides far better homogeneous fat suppression. The disadvantages, however, you would wonder why we can't use stir sequence for all sports injuries. The problem with it, though, is the scan time is longer. And the reason why the scan time is longer is because we need to increase the number of excitations to improve the SNR, because this inversion recovery has inferior SNR compared to fat saturation, and that results in fatigue and motion artifact. Here is an example of two cases, the same patient, same anatomy, imaged with T2 fat saturated on the left and stir sequence on the right. And you can appreciate the differences here in terms of the homogeneity of the fat suppression. On the left, we see that there is failure of fat suppression in the periphery of the anatomy because it's a larger field of view with complex air soft tissue interfaces, but that has significantly improved with using stir sequence. So if you were to supervise a case like that and the MRI technologist is asking for your opinion to overcome this problem, you just always prefer to switch to a stir sequence. Planes are very important. Selecting your anatomical plane is always important with sports injuries. Axial plane is mandatory, is always available in the protocol. The second orthogonal plane depends on where the pathology is. And if we're talking about the upper or lower extremity, if the pathology is medial or lateral, we would go with the coronal plane. If the pathology is anterior or posterior, then we would go with the sagittal plane. It's also vital that you remind the MRI technologist to place a marker where the pathology is. And this is quite important if you are dealing with an old injury. Because dealing with acute injuries is easier, much easier than dealing with an old injury, because with old injury, we don't really see soft tissue fluid. Now we move on to the spectrum of sport injuries, and we will go through the specific tissue approach here. We start with muscle injuries. Our MRI protocol, if a patient was referred to us for muscle injury, it's very simple MRI protocol. It really includes just two sequences and two planes. And the two sequences, we always have a T1 axial, and that's for our anatomy, because identifying which muscle is involved is important. And we would do that by having a T1, axial T1, then we know which muscle we're dealing with. And then we have a fluid sensitive sequence such as STER or T2FS. And then you choose your second orthogonal plane depending on where the pathology is. We don't routinely administer contrast when we're dealing with muscle injuries. The only time we administer contrast is if we have confusion whether actually this is a muscle hematoma, muscle tear with hematoma versus sarcoma. Spectrum of injuries, as far as muscles are concerned, would range from myotendinous tears to myofascial tears, muscle contusion, and muscle hernia. And we will see examples of these. But before we do that, we would really need to have some understanding about muscle physiology. There are different types of muscle contractions. The isometric muscle contraction is when the muscle contracts, but there is no change in the length of the muscle. Concentric contraction is when the muscle contracts and shortens. Eccentric contraction when the muscle contracts but lengthens. And the eccentric contraction is actually the one that carries the higher risk for muscle tears. Some anatomic considerations are also important to understand. There are inherent risk factors to make some muscles are more prone to muscle tears than others. And an example of that is the biarticular muscles, i.e. muscles that cross two joints. And the most familiar example for you is the biceps muscle, because it crosses the shoulder joint and the elbow joint, therefore makes it very much prone for muscle injuries. Also, another anatomic understanding or consideration for muscle tears is understanding the muscle pennation. And that would give you some answers as to why sometimes you see a muscle tear or myotendinous junction tear is peripheral in the muscle. However, other muscles have a central myotendinous junction tear. So if we take up the example on the left-hand side, it's a rectus femoris muscle. The myotendinous tear is actually centered within the muscle belly itself. And the reason for that is because rectus femoris muscle is a bipinnate muscle. However, if we look, for example, at the medial head of the gastrocnemius muscle, the myotendinous junction tear is peripheral, is on the side of the muscle because it's a unipinnate muscle. Quantifying muscle injuries is very important for management, deciding whether to treat patients conservatively or surgically. There is clinical grading and MRI grading. We'll go over the MRI grading. And by the way, this grading system is only for acute muscle injuries. For chronic muscle injuries, really all what we see is muscle atrophy with fatty infiltration. So what are the stages or the grading for the acute muscle injuries? Grade 1, when you only see muscle edema, such as, for example, here in this rectus femoris muscle and the tensor fascia lata, you see muscle edema, but there is no disruption of the muscle fibers. So this is a grade 1 muscle strain injury. Grade 2 strain injury, however, is, for example, in this iliopsoas muscle, you will see diffuse muscle edema with disruption of the muscle fibers. So this is a grade 2 muscle strain injury. Studies have shown actually the length of the tear is more important than the width of the tear. A study was published by David Connell in HAR showed that the longer the tear in the craniocaudal dimension, the longer the recovery of this player before they return to sports. Grade 3 muscle injury is when you see complete disruption of the myotendinous junction, as we see in this conjoint tendon of the hamstring muscle. There's complete tearing of the proximal myotendinous junction with fluid-filled cleft. As another example of grade 3 muscle strain injury, the medial head of the gastrocnemius muscle, really large tear of the myotendinous junction with fluid-filled cleft. This this particular type of injury is always referred to as tennis leg, just to be familiar with this terminology. So we have talked about the myotendinous junction tears of the muscle, but remember that injuries in the muscle could also occur at the myofascial junction, such as, for example, this patient who suffered myofascial injury of the vastus lateralis. So you would appreciate that the myotendinous junction is here, there is muscle edema, but the fluid actually cleft is situated between the muscle and the epimysium. So always be mindful that muscle injuries can be quite diverse, and just knowing your anatomy and knowing your basics, you can actually provide accurate diagnosis. Move on to a different type of muscle injury is muscle hernia, and muscle hernia occurs when there is a tearing of the epimysium, and epimysium is that sheath that surrounds the muscle. So an example of that is this patient with extensor compartment muscle hernia due to a tear of the epimysium. From my experience, I actually prefer to do an ultrasound on these patients rather than MRI, because with ultrasound, I would be able to do dynamic examination and compare the two sides. Chronic muscle injury, however, is different. As I mentioned earlier, all what you see is actually muscle atrophy with fatty infiltration. So if we compare here the right and the left rectus femoris muscles, we see actually there is muscle atrophy and fatty infiltration on the right side. And this is how chronic muscle injury looks like. MRI pitfalls in muscle imaging, you just need to be mindful that sometimes muscle appear hyper intense on MRI, and that's normal for the muscle, particularly muscles that have parallel fibers anatomy. An example for that is the thenar compartment and the pronator quadratus. So you would always see some signal change in these muscles, and that's just because the anatomy of the muscle. Move on to tendon injuries. MRI protocol for tendon injuries. In our institute, we always have a PDFS, T1 and T2. And T2 is always in the protocol, particularly in the rotator cuff anatomy or imaging, because of the magic angle effect that you would encounter with proton density fat suppressed method. The tendon normally appears homogeneously hypointense. So this is how the tendon looks like. And with positioning techniques, as far as the tendons are concerned, there are certain tips that we would always want to have with imaging certain tendons. For example, imaging the rotator cuff tendons, we would always have the shoulder in external rotation to again avoid the magic angle effect. And imaging the distal biceps tendon, you would always want to have the patient in FAPS position, which is flexion, abduction, supination, and that's how it looks like. It looks like more like a yo-yo. So that's your FAPS technique for imaging the distal biceps tendon. Certain tendons or tearing or injuries of certain tendons have surgical implications. So always important to remember that rotator cuff tendons are the major stabilizers of the shoulder joint. Therefore, they have surgical implications. Achilles tendon is the major plantar flexor of the ankle, extensor mechanism of the knee, and the distal biceps tendon. So injuries of these tendons always have surgical implications. I chose the shoulder joint for the tendons because, again, as I mentioned earlier, because the rotator cuff tendons are the major primary stabilizers of the shoulder joint. This is our shoulder MRI protocol at our institute. We use PDFS in 3 planes. We use coronal T2 to mitigate the magic angle effect. We have sagittal T1. This is to quantify muscle atrophy and fatty infiltration. So how does a tendon injury looks like? It really ranges from the nature of the injury. If you're dealing with repetitive injury, repetitive strain, then you would be dealing with kind of gradual disintegration of the tendon, and the tendon appears heterogeneous with signal change, such as in this supraspinatus tendon. Remember how tendon should look like. It should look homogeneously hypointense. So this is actually how tendinosis looks like. And always look for the coronal T2 as well, just to make sure that you're not really over-diagnosing tendinosis in case there is magic angle effect. So you should always look for matching between the coronal PDFS and the coronal T2. Partial thickness tears. This is an example of articular-sided partial thickness tear of the insertion of the supraspinatus tendon, focal defect at the articular surface with high signal intensity, again matching coronal PDFS with coronal T2. Full thickness tear, we see an example here of complete full thickness tear of the supraspinatus tendon with tendon retraction. As I mentioned earlier, this actually has surgical implications, and because of the surgical implications, we would want to quantify how much left of the muscle, because that's what helps the surgeons decide whether to operate or repair this tendon tear or not. And for that, we would quantify the size of the supraspinatus muscle using the tangent line, which is a line touching the superior cortex of the coracoid process, superior cortex of the spinous process. Normally, about 1/3 or 1/4 of the supraspinatus muscle should be sticking above that line. And here what we see, it's just a tiny portion of the muscle is above the line. So that would be in keeping with kind of moderate muscle wasting. We'd also use the guttular fatty infiltration grading system to quantify how much fat within the muscle. So always provide this information in your report to the surgeons, because that would help them decide whether the tear is proper or not. In terms of MRI artifacts, magic angle effect is the biggest problem here with tendon imaging, particularly supraspinatus tendon, because of the angle. And always look for the coronal T2. Look for matching or for a match or a mismatch. So in this example, for this patient, for example, we see high signal intensity in the supraspinatus tendon. However, the coronal T2 looks completely normal. So then we know we are dealing with a magic angle effect. Now we move on to ligamentous injuries, and I've chosen the knee because in the knee, ligaments are the major stabilizers of the knee. Remember, we said in the shoulder, tendons are the major stabilizers, but in the knee, ligaments are the major stabilizers. And it's understanding the pattern of injury is very crucial, because then you would have an idea at what ligaments may be injured because of the mechanism of injury. So these are some recognizable patterns. Pivot shift injury is associated with ACL and MCL, hyperextension mechanism associated with cruciate injuries, valgus mechanism of injury associated with MCL, and varus mechanism of injury associated with LCL. This is our knee MRI protocol. We have PDFS in 3 planes. We have coronal PD space sequence, a high resolution, isotropic imaging of the knee. We could use multiplanar reconstruction on this sequence. It's a longer sequence, but it's worth it. We also have sagittal T1, and we should always have a T1 sequence, whether you are imaging the shoulder or the knee, any joint, this should always be a T1 sequence. Quantifying ligamentous injury, there's a clinical and MRI quantification methods. As far as the MRI quantification method, this is how a normal, let's take the MCL, for example, this is how a normal ligament should look like. It's thin, homogeneous, hypointense in signal intensity. This is a normal MCL. This is grade 1 MCL sprain injury. What we see here, although the ligament remains hypointense and linear and homogeneous, there is periligamentous edema. And you can see it even on the axial PDFS. And this is in keeping with grade 1 MCL, and there is no disruption of the ligament here. However, in grade 2 ligamentous injury, we see thickening, striation, and partial disruption of the femoral attachment of the MCL. This is in keeping with grade 2 MCL injury. Grade 3 MCL injury is complete disruption with fluid-filled gap at the femoral attachment of the MCL. This is grade 3 MCL injury. Chronic MCL injury can be challenging, and just recognizing how chronic MCL injury looks like could actually help you identify this entity. And just I put these images side by side. This is a normal MCL here on the left and a chronic tear of the MCL on the right. You see this thickening, quite markedly thickened MCL, although it's hypointense, but it's quite thickened. There is also calcification here. I don't have the X-ray, but this is actually calcification on the X-ray, and this would be in keeping with Pellegrini's theater. It's calcification at the femoral attachment of the MCL in keeping with chronic MCL injury. Move on to cartilaginous injuries. There are different types of cartilage. We are only interested in the hyaline and fibrocartilage. Imaging the fibrocartilage, we always have the PDFS and PD space sequence in the knee, for example, and the cartilage appears intermediate signal intensity on the PDFS or PD space, as we see here in the coronal PDFS and the coronal PD space. There's a spectrum of injuries if the cartilage is subjected to an external force. There is a range of injuries that can happen, ranging from an acute osteochondral fracture to acute osteochondral impaction injury, subchondral fracture, and osteochondritis dissecans, depending on the severity of the injury and the duration it took. For example, here we have a patient who suffered lateral patellar dislocation, and you can recognize that by the kissing bruise here over the lateral aspect of the lateral femoral condyle and the medial aspect of the patella. And we can see as well that there is an acute osteochondral fracture of the anterior articular surface of the lateral femoral condyle. We can identify that by the sharply marginated donor site here, the sharply marginated osteochondral defect in the lateral femoral condyle with a displaced osteochondral fragment here in the anterior aspect of the tibiofemoral joint. So this is how acute osteochondral fracture looks like. We always want to identify where the fragment is. And the reason for that is sometimes surgeon actually could go in and reattach this fragment. And also leaving the fragment inside the joint could cause mechanical problems such as locking of the knee. Here is another example of cartilage injury called osteochondral impaction injury. An osteochondral impaction injury, how you recognize it, is focal area of incongruency of the articular surface associated with subarticular edema. And this is what we see here in this lateral femoral condyle. There is an articular depression here with signal change. This is an osteochondral impaction injury. Another pattern of cartilage injury is that when the cartilage remains intact, however, the bone under the cartilage is fractured, and we identify that with a linear hypointense signal intensity in the subarticular region associated with edema. So this is subarticular fracture. If the injury is chronic, repetitive, such as, for example, in gymnasts, because they do a lot of repetitive axial loading of the upper limb, then you can actually have an entity which is more like osteochondritis dissecans, for example, and this Panner's disease, this young athlete, 15-year-old gymnast. And what we see here is focal area of osteochondral lesion involving the capitellum, and the fragment itself is detached and fragmented. Move on to fibrocartilage. So we have three types of tissue here: the meniscus, the labrum, the TFC. The fibrocartilage should always, in terms of imaging, we always rely on a short TE sequence for imaging the fibrocartilage, and this would include PDFS or T1 fast saturated if you're using orthographic technique. Fibrocartilage always appears hypointense on all the sequences. We start with the menisci. There's a grading system for meniscal changes. Grade 0 is when the meniscus is homogeneously hypointense with no signal change. Grade 1 is when you see signal change in the meniscus, but that signal change does not breach the articular surface. So this is grade 1 signal change of the meniscus. Grade 2 signal change is when you see linear signal change in the meniscus. Again, no breach of the articular surface. Grade 3 meniscal change is actually, by definition, is a meniscal tear, because there is a signal change, but that signal change breaches the articular surfaces. Complex meniscal tear is a multidirectional meniscal tear. Move on to the labrum. The labrum actually can be seen in the glenoid acetabulum, but also can be seen in the ankle joint. We published an article in 2017 where we provided MRI description of the posterior ankle labrum based on anatomic cadaveric studies. The labrum, again, like the meniscus, should appear homogeneously hypointense on the short TE sequences, and this is our MRI protocol for the glenoid labral imaging. We always use orthographic technique for the shoulder, whether it's 1.5 or 3 Tesla scanner, and these are our sequences for imaging the glenoid labrum. Here is an example of a patient with type 2 slap tear, and slap tear is anteroposterior labral tear. We see fluid-filled and contrast-filled defect in the superior labrum. Here we have a patient with Bankart lesion, and again, we need to go back to basics and understand the definition of Bankart lesion. Bankart lesion is anteroinferior labral tear or labral detachment with periosteal sleeve avulsion. So this is, by definition, a Bankart lesion. Ellipsa lesion, however, is, again, anteroinferior labral tear with medial displacement, medially displaced, but the periosteal sleeve is intact. So this is ellipsa lesion, which stands for anterior labroligamentous periosteal sleeve avulsion. Perthes lesion is anteroinferior labral detachment with intact periosteal sleeve. This is a Perthes lesion, and all these studies are orthographic studies. When we describe labral tearing or labral injuries, we have to also provide further information. We have to quantify the extent of the labral tear using the clock phase. We also should comment on any associated cartilage injuries, such as a glad lesion, for example, in the shoulder. We also should comment on whether or not there are paralabral cysts. So, for example, this patient with posterior labral tear developed rather large paralabral cyst, which actually extended to the quadrilateral space, causing mass effect of the neurovascular bundle. And what we see is denervation myositis of the deltoid anterior minor muscle in keeping with axillary nerve entrapment. So always comment. The reason why it is always important as well, because arthroscopic surgery would overlook paralabral cyst. They won't be able to see the cyst when they go inside and look around. So it's always helpful to provide this information. Move on to the acetabular injuries. The imaging methods we provide could be either orthographic using the 1.503 Tesla scanner. And here we have an example of orthographic imaging of the hip joint. We see contrast gadolinium, dilute gadolinium in the joint, and we see contrast extending into a labral defect in the anterosuperior aspect and keeping with a labral tear. Imaging of the labrum could also be, the acetabular labrum could also be non-orthographic, but this non-orthographic technique is only used using the 3 Tesla scanner. Here we have an example of a patient imaged using non-orthographic FAI imaging protocol using 3 Tesla scanner, and we see articular side defect in the anterosuperior labrum. Imaging of the triangular fibrocartilage is always orthographic in our center. So this is an example of wrist arthrogram. These are our sequences we use for the TFC imaging. And in this particular patient, we have palmar type 1A and type 1B. A is central defect in the cartilage, and B is detachment from the ulnar attachment of the TFC. Remember your palmar classification, type 1 is traumatic, type 2 is degenerative. Now we move on to bony injuries. MRI imaging for suspected bony injury relies heavily on T1 and STIR sequence, and T1 is used to detect trabecular lines, trabecular hypointense lines, and STIR sequence is really to detect the associated muscle edema. The spectrum of bony injuries range from bony contusion to trabecular microfractures to bony impaction injuries and stress fractures. This is an example of bony contusion injury. What we see here is a kissing contusion of the anterior aspect of the lateral femoral condyle and lateral tibial plateau. And actually the advantages of bony contusion, it helps us predict the mechanism of injury. So for example, in this patient, we know the mechanism of injury by just looking at the bony contusion. This must have been a hyperextension injury. Another pattern of bony contusion is when it happens in the periarticular aspect of the lateral tibiofemoral compartment. Then we would recognize that by looking at the pattern of the bony contusion, this must have been a valgus stress mechanism of injury. And if you look medially, you see bony avulsion injury of the MCL. Another pattern of bony contusion is the pivot shift pattern bony contusion, when we see bony contusion of the anterior articular aspect of the lateral femoral condyle and the posterior aspect of the lateral tibial plateau. Then by recognizing this pattern of injury, then we know this patient suffered pivot shift mechanism of injury. Trabecular microfracture is recognized by identifying these hypointense lines on T1. And if you look at your fluid sensitive sequence, you see there is associated edema in the bone. So this is a trabecular microfracture. Bony impaction injury, a best example for that is Hill-Sachs deformity or Hill-Sachs lesion in this patient who suffered anterior shoulder dislocation. And we recognize it by identifying the focal concavity at the posterior superior aspect of the humeral head. Stress fracture is recognized by identifying linear hypointense line in the bone with surrounding edema. Move on to apophyseal injuries. And apophyseal injuries happen because of the repetitive overuse of the tendon-bone interface. For example, we have this patient who is a basketball player, developed jumper's knee, or Sinding-Larsen-Johansson syndrome. is traction apophysitis of the inferior pole of the patella, which is demonstrated by fragmentation of the inferior pole as we see on the X-ray. We see osseous edema as well as thickening and hyperintensity of the patellar tendon proximally. Another pattern of traction apophysitis is Osgood-Schlatter's disease. It's traction apophysitis of the tibial tuberosity apophysis, again as a secondary to extensor mechanism overuse. Another example of traction apophysitis is little league Alpo, and we see edema of the medial humeral epicondyle in this patient who happened to be a baseball pitcher. And we can see that on MRI on the coronal fluid sensitive as well as in the axial fluid sensitive sequences. Move on to bursal injuries. I have an example here of olecranon post-traumatic olecranon bursitis. This patient had a fall and suffered posterior elbow dislocation and developed fluid within the olecranon bursa. But post-traumatic bursitis tend to affect bursae that cover bony prominences, such as the olecranon bursa or the prepatellar bursae. That's where you recognize post-traumatic bursitis. Fascial injury, the most familiar example is actually Morel Lavallee. They love it here in Canada. Each examiner would have one of these cases in their teaching file or exam file. And this happens due to rapid deceleration after fall. So you get kind of degloving injury between the subcutaneous fat and the deep fascia. And what you end up having is a fluid-filled cavity here with these fat lobules. And these fat lobules represent fat necrosis. So just recognizing the pattern of injury here. Okay, so to summarize, this talk provided practical tips on MRI imaging of sport injuries. We talked about positioning, sequences, coils, scanners, artifacts, how to overcome artifacts and recognize artifacts. We provided definitions and terminology of sports imaging. We kind of go back to basic and understand what ellipsa is, what Bankart lesion is, and Perthes lesion is, just so that we don't confuse them. We provided a pictorial, kind of broad pictorial review of the most common sport injuries, provided description of soft tissue changes, MRI characteristics, anatomic considerations, as in the case with muscle injuries, the biarticular muscles, the muscle pination, and how this would affect the MRI appearances of muscle injuries, also recognizing different patterns of muscle injuries, such as the myotenous junction tear or the myofascial tear, and just identifying where the tear is. Also, we provided some information about quantifying soft tissue injuries, the grading system that you could use for ligamentous injuries or muscle strain injuries. Okay, so that's the end. I hope you liked it. And if you have any questions, please go ahead.
Can I ask a question?
Hello.
Absolutely.
Hi, Haron. Hema here.
Hey,
Do you comment, hi,